Hello, everyone, and welcome back to a Clinical Problem Solvers session. This is another episode of the Rafael Medina Subspecialty. I'm Jimena, and I am part of the CP Solvers Academy team, and I have here my dear friend Ibrahim, who will join me in facilitating this session. Today, we're going to talk about pulmonary and critical care medicine, and we have two wonderful guests. As a case discussant, we have Dr. Natalie Achamallah and we have Nivedita Kharkongor, who will present a case for us today. I want to briefly introduce Dr. Achamallah, who I have the pleasure to know and learn from her pretty often, I would say. She's the Director of Critical Care Education for the Internal Medicine Residency at Santa Barbara Cottage Hospital, as well as a Clinical Assistant Professor at USC Keck Medical School. And she's currently a practicing intensivist and pulmonologist. Her journey actually started when she did med school at the Royal College of Surgeons in Dublin, Ireland. And she decided to come back to California, where she did her internal medicine residency at Santa Barbara Cottage Hospital. And I'm thinking that she loved California so much that she decided to do her pulmonary and critical care fellowship at Cedars-Sinai Medical Center in LA. And fortunately, she decided to return back to Cottage Hospital in 2022 to join the faculty. I'm going to let her introduce herself, but not without saying that she's a wonderful teacher, and I'm really excited to have her today in this VMR. Hi, Dr. Achamallah.
Hi, thank you for having me. I'm really excited to be here.
Thank you so much for agreeing to do this. I think that one of the questions that we all think about is why certain specialties. So can you share with us why did you decide to do Pullman Crit?
Yeah, I actually decided to do crit. Which I think is pretty common for most people that go into pulm crit. They get into the intensive care unit. They really feel like this is my place. This is where I belong. I love critical care. And, not all of us come around to pulmonary really before we start fellowship. And then, the two really go hand in hand. And most people by the time they finish fellowship are more excited by the pulmonary than the critical care. And I think that that continues throughout the journey for most people. Don't get me wrong, I like pulmonary medicine a lot. It's fascinating. It still, confuses me and mystifies me every day, but I still think that ICU is my happy place. But it's nice to have the balance of both of them in one specialty.
Awesome. I think that you gave a pretty accurate description of how people decide to start this fellowship. And then just to keep it casual, what do you like to do for fun outside of medicine?
Oh, so I like making things. That's kind of my favorite. Any of my favorite hobbies, I like to paint, I like to cook, I like to garden. I like to hang out with my husband. He's my favorite person. I know that's gross, but he's a lot of fun.
Thank you so much for sharing that. Now I'm gonna pass the mic to Ibrahim, who's gonna introduce our wonderful case presenter.
Thank you so much, Jimena, for the wonderful introduction and for Dr. Achamallah for joining us for today. My name is Ibrahim, and I'm a CPS member, and I'm so happy to be here today. I actually met Nivedita on my internal medicine sub-internship when I was in Baltimore. So Nivedita, I'm gonna pass the mic to you to introduce yourself to the audience. So go ahead, my friend.
Hi, everyone. Thanks, Ibrahim. It's so nice being here. Thank you for inviting me so I could present this case. My name is Nivedita. I'm a current PGY3 internal medicine resident. And actually, I'm going into sleep medicine for the next year.
And Nivedita, would you like to talk more about your journey to sleep medicine and what you want to pursue following that?
I feel like whenever I give this this talk about how I get into what I wanted to do. It sounds like I have a little bit of ADHD, because I feel like when I got into med school, I liked everything under the sun. And then I did internal medicine, and then I went in and I was like, I want to do this. I thought for a little bit, when I was on my endocrine rotation, I thought I would do endocrinology. When I was on my cards rotation, I was like, I would like to do cardiology. And then when I was in the ICU, it was like, oh my God, I get to see everything here. It's so much fun. And then the more I did ICU, I was like, this is fun. And then I did more pulm. And funnily enough, I found that everything exists about what I like. There's infectious disease, there's vasculitis, there's malignancy, there's rheumatology within the lung itself. So I find that it's a very fascinating organ to look into. And then sometime at the end of second year, when I was getting really tired, I was like, how would I do this for the rest of my life? And then I thought that I would want to have something else as well. So I tried to do a sleep rotation, and I was like, this is nice too. So that's where I ended up. So I'm going to do a sleep medicine rotation for a fellowship for a year, and then I'll try applying again for Palm Crit. So that's my ADHD response.
Well, best of luck. I'm sure you're gonna do well. So I guess now that we've introduced everyone, Dan, if you can pull up the whiteboard, then we can start with the case.
Yes, all right. Give me 1 second. Okay. Can you guys see that?
We can.
Okay.
So Nivedita, whenever you're ready, please feel free to go ahead.
Okay, awesome. So I have here with me, we have a 66-year-old female. She has a past medical history of insulin-dependent type 2 diabetes mellitus, hypothyroidism. She had a history of a patent foramen ovale with a closure back in 2021, a history of a DVT and pulmonary embolism. She is on apixaban since 2020. And she has history of peripheral arterial disease with a bilateral thrombectomy and fasciotomy, which led to a left lower extremity above knee amputation and right lower extremity TMA. So essentially, she comes in because she began having shortness of breath that began to progressively get worse over 4 weeks. And this was associated with headache, runny nose, congestion, a postnasal drip, and a new productive cough that began a week before she presented to us. And that's where I'll leave it.
Is she presenting in the clinic, or is she in the emergency department?
Emergency department.
Okay. So clearly a lot of vascular history. I would be worried about her cardiac function right off the bat. I would want to have some kind of background on that. Shortness of breath worsening over 4 weeks, kind of interested in what made her finally present. Did she have an acute worsening, or did she just decide that she couldn't take it anymore? Did she not have kind of an outpatient person that she could go and discuss this with? As far as the new productive cough, I mean, is anyone around her sick? Has she had symptoms like this before? And what exposures really happened right before this? Postnasal drip, headaches, etc.
So we found out that prior to this, she was having all of these symptoms, and then she went to an urgent care to get herself looked at. They gave her a sleep bag and some over-the-counter supplements, no steroids at that point of time. She said that she felt some improvement, and then she tried some nebulizations at home. However, she decided to come to us because she, like you were saying, she just couldn't take it anymore. She felt like she couldn't sit still, and she was just so short of breath and uncomfortable just being what she was. In terms of exposures, she lives on a separate floor of her family, so she made sure that no one around her was sick, especially because she began having the symptoms first. She didn't know there were no pets around that were new as well in terms of that, and nothing else that she noticed besides that.
I'm seeing her in the emergency department. How does she eyeball? What do her vital signs look like?
So first survey, she looks sick. When we go in, she's huffing and puffing. You can actually see her being completely tachypnic. She's around 22 to 26 respiratory rates per a minute. When we checked her on the pulse ox, she was around 84, 84%. The main thing was she wasn't able to complete any sentences. She required immediately to be put on high flow nasal cannula, and then her oxygenation improved with that on 100% to 96.
Does her tachypnea also improve? Does she look less labored on the high flow?
Yes.
Okay. So somebody that looks this sick, I think I would go straight for an ABG and a chest x-ray, because those are results that I get back pretty quickly and that I can intervene on pretty quickly.
So that's what we did. And then we did get the ABG around that time. And her pH was 7.33. Most importantly, her PO2 on that 100% FiO2 was 55. Her PCO2 was 47, and her bicarb from the BMP, which was or bicarb on the ABG, was around 25, which was correlating with her bicarb on the BMP that she had. I have a chest X-ray that she had on admission, which I can share with the team.
So Nivedita, were you
Yes.
going to show the chest X-ray at this point, or was this supposed to go
We-
on later?
I can show it because it's the first one.
Okay. Okay. I just wanted to make sure, just like not to mess up with like the whole sequence you have in mind. But,
Okay.
We can wait as well.
Do
And
you,
then we
whatever
can.
you prefer. Yeah,
Okay.
whatever you prefer.
So yeah, we got the chest X. You're still gonna be interesting though, so I'll show that to you. Just give me 1 second.
I'm impatient. I'm an intensivist. And I'll tell you, I'll tell you a little bit why. So, this is a person who, it's like I said, I don't have full information yet. I probably would put an ultrasound on this person's chest in the ER and try to get a sense of their cardiac function. So, vascular path with kind of progressive onset dyspnea. We didn't talk about on her exam if she has signs of volume overload, but if this looks like heart failure exacerbation, she may look a little bit better on the high flow, but it's probably somebody, just looking at the gas especially, that I would be trying to get on positive pressure ventilation sooner than later. So having an x-ray that shows me pretty clear pulmonary edema, looking at my ultrasound, do I have B lines? Do I have pleural effusions? That's a person I'm going to treat a little bit differently than if she has a pattern that looks more like a pneumonia, which she also has some suggestion of that, and then might go down a sepsis pathway.
Let me just pull this up. And okay. Oh, sorry. That's what it is.
Okay. All right. So let's see, semi-erect, so not ideal positioning. AP, she's too sick clearly to go for a PA film. She looks like she has definitely some vascular redistribution. She has these kind of fluffy cotton ball infiltrates throughout the lung fields. They look like they're more probably prominent in the upper middle lobe and lingula. I can still see the diaphragm pretty clearly on the right. I can't see the full diaphragm on the left. So that is really, really hard to interpret in a non-upright chest x-ray because fluid layers a little bit differently than if somebody is upright. So I don't know if I can rely on not seeing that classic like blunting of the costophrenic angle. All of the heart borders have that kind of shaggy appearance, which is why I think that there's a lot of anterior changes as well. You could convince me that there's some air bronchograms on the left side and the hilum, which might point to some more like dense consolidations, not necessarily fluffy edema. and there's really, really generous left hilum. So I wish I could point with my finger at what I'm looking at, but in the space between the aortic knob and the left heart border, where there should be a little indenting, yeah, there's kind of a clear straight border, and same thing on the other side, there's some fullness. So this might be a person that has some kind of chronic heart disease with some pulmonary hypertension underlying. She doesn't have any devices that I can see, with the exception of the leads that are on her. She's probably not on the high flow nasal cannula yet at this point because I can't see the tubing, but maybe it's just out of view.
So that's essentially what our radiologists and what we sort of thought as well. So when she came in, we looked back at her history. We put her actually on a BiPAP at that point of time, took her to the ICU step down unit, and we started our workup. And then essentially at this point, she was treated with diuretics. We also started her on broad spectrum antibiotics, given how sick she looked. And then she was already on Eliquis for a possible pulmonary embolism, just given how hypoxemic she was. At that point of time, we did get a point of care ultrasound. It didn't look like she had, I don't have images for that, but it didn't look like she had any right ventricular strain as well. And she did have some dilation of her IVC, which is why we decided with the IV diuretics.
We talked a little bit about her respiratory status, her other vital signs.
So she was hemodynamically stable. Blood pressure was at 100/70. She was afebrile. This was before any Tylenol administration. And her heart rate was around 100.
And then any other notable, we talked a little bit about her work of breathing, but anything else notable on her physical exam? What does her volume status look like? And how is she encephalopathic? Is she able to communicate? I know you mentioned that she couldn't speak in full sentences. Again, that's a total red flag.
So in terms of just how she looked during the first survey, when we saw her, it looked like she was trying to speak. Didn't look like she was altered in any way, but she just wasn't able to complete any sentence at all, and she was just huffing and puffing. There was a lot of accessory muscle use that we looked at. If there was any pharyngeal erythema, anything in her back, nothing like that. In terms of her cardiovascular examination, there was nothing that was pertinent for us. There was no murmurs. It was difficult to assess for volume status, just given her body habitus. Her neck was a little bit short as well, so we weren't able to tell that. And she did have the transmetatarsal amputation and the above knee, the stump as well, so we weren't able to look at any pedal edema as well, per se. The stump, however, itself didn't look particularly edematous, that she said that she would indicate that was different. And at baseline, she was using a wheelchair from what we found out.
And then on auscultation, was she moving air? Are you hearing crackles? Did she have wheeze?
So she did have inspiratory crackles, bilateral lung feels, no wheezing, and there was air movement that was equal, and there was no air trapping that was noticed, and no digital clubbing that we could see.
So with the information that it has been given so far, Dr. Achamallah, what is on your mind right now, and what are your concerns? Where is your differential diagnosis right now?
So kind of two competing diagnoses, which could honestly exist in tandem or one on the background of another. I don't usually think of an acute infection or acute infectious process as leading somebody to have 4 weeks of progressive symptoms. It does seem like there's a change in the last week. So, the simplest explanation is one unifying one, but some people that have a chronic illness that's progressive, something tips them over the edge, which makes them finally come in. The chest x-ray findings are not a slam dunk for pulmonary edema. The air bronchograms and the lack of the lack of pleural effusions actually make me a little bit more worried about an infectious cause, especially with the productive cough. So I agree with starting with the broad spectrum antibiotics. I would be looking to see, I don't know what time of year this person presented, but I would be doing a flu swab, I would be doing a COVID swab, or if you have the luxury of a respiratory viral panel, I would be doing that too. Trying to get sputum if I could, getting blood cultures. I might also, I might also start her on nebulizers through the BiPAP and see if she has any improved comfort with that. And then we don't have labs back yet, but then inflammatory markers and, besides your basic chemistry and your blood counts would be helpful. And then I think that's where I would start. Oh, I didn't mention the other differential, which is pulmonary edema. It seems like maybe it exists in the background, but probably not the major player at this moment.
And then, in terms of PE, because that's usually like always hunting us when we talk about shortness of breath and pulmonary and critical medicine. She, as you mentioned previously, she has history of having vascular problems, although she was on Eliquis. And it doesn't seem to be like a super acute presentation, but she was very hypoxemic. So what do you think about PE at this point?
Yeah, I am, I'm pretty reassured. I would want to know, I know that she's supposed to be on Eliquis. I would want to know if she's actually been taking the Eliquis. I imagine that coags are going to be among the labs that you're going to get. A 10A would be helpful with that to see if she's actually feeling the effect of it. If we'd had a totally clear chest x-ray, then I would be much more concerned about a PE given this history. But with that much pathology in somebody who is theoretically on their Eliquis, unless there's a reason that we think that she had Eliquis failure, which if she's been on it since 2020, I would be expecting that to happen much earlier, then it's a lot lower on my list of differentials.
Thanks for answering those questions. Nivedita, can you please tell us more information about the case?
Okay, so just coming back to the history, I'll give you a little bit more background. So she, in terms of her social history, she's retired. She used to work in the FBI previously. But that she retired sometime around when all of these incidents happened back in 2020. She has had difficulty traveling to most places out of the Baltimore, Maryland area, essentially. And to answer your question, all of these, this patient came back. This patient presented to us around, I would say, in January. She has no children. She lives with her sister. She is an ex-smoker. She used to smoke a half pack per day of cigarettes for 20 years, but she quit in 2020 when she was afflicted with all of these conditions that happened. We also went back to get a family history, and she has a family history of breast cancer in her sister, diabetes in her dad and her mom. So essentially what we did after after triaging her, bringing her up to the ICU step down, we did get a CBC at that point of time. There was mild leukocytosis. It was around 14,000. No, her platelets were also normal. H&H was stable, no concerns there. In terms of her electrolytes as well, no electrolyte abnormalities. She had good kidney function, no elevations in her liver functions as well. Her pro-BNP, and this is in the setting of someone who is on the higher BMI side. Her pro-BNP was around 2,663. And we did get 3 troponins. All of them were, and these are high sensitivity, so all of them were around 12, 11, and 9. We did get the respiratory viral panel, which was the extensive one. It was negative for everything, including RSV, and her Legionella and strep pneumoantigen was also negative. We did get inflammatory markers such as the SED rate and the CRP, and that was the only thing that was elevated.
Procalcitonin?
Procalcitonin, let me see. I'm not sure. I think we did get it and it was elevated on admission.
Okay, fair enough. And then humor me because I'm a pulmonologist. Does she have eosinophils on the diff for the CBC?
Let me pull that up. I am not sure. Yeah, I'm not sure.
Okay, fair enough. Yeah. If you would have told me that that was going to become my favorite lab test when I was in residency, I would have been so confused. But, you know, really, especially in somebody that comes in with a pneumonia, with this kind of respiratory failure out of proportion, you know, I always want to know, and again, this is my skewed perspective, I also always want to know if they kind of skew towards an allergic or an atopic phenotype. Because that might make me more likely to treat them with steroids. It might make me more likely to continue them on inhaler therapies for a reactive airways component after they discharge. There's also some kind of infectious diseases that tend to give you a higher eosinophil count, and some more chronic pulmonary diseases. We see a lot of valley fever or cocci in California. So the eosinophils can be a hint there. Cocci is a great mimicker and can look like really anything on a CT scan. I saw a question about procalcitonin significance. I'm sorry, I don't remember. I didn't see the whole question in the chat.
They're asking, what is the significance of procalcitonin if not COPD?
Yeah. So the ESR and the CRP can be elevated really in many acute processes, infectious and non-infectious. If I see an elevated procalcitonin, I'm more likely to believe in a bacterial process that on top of let's say somebody that has a viral pneumonia, if the procalcitonin is elevated, I'm much more likely to think that there's a bacterial component as well. And it's appropriate that this patient was started on broad spectrum antibiotics. Looking at that BNP too, I'm a little surprised, honestly, by the bedside focus. You know, sometimes in somebody even with some underlying heart disease, having a new septic illness, they can come into with a cardiomyopathy related to that. So I'm glad that we have a view of the LV function. My guess is that she probably has some diastolic dysfunction, and the diuresis is appropriate in this situation.
Perfect. Do you have any more information, or are we going to jump right into imaging? Because I know that's key.
Itching to see the CT scan, yeah.
Yes.
We did get a CT scan with IV contrast at that point of time, and I can just share the imaging.
Was the IV contrast for the PE protocol?
Yes.
Yeah.
Can you share with us why are you asking that question, Dr. Achamallah?
Honestly, it's because this more happens in the outpatient world. When I see a CT with IV contrast, it kind of makes me cry a little bit on the inside. It's good for looking at mediastinal processes, but in general, if you're looking at the parenchyma, a CT scan without contrast is the best study. The CT angiogram with PE protocol, it's helpful if that's high on your differential. It's not a substitute though for the CT without contrast because the cuts are different. So getting a good high resolution picture of the lung parenchyma on a PE study is not as good as the regular CT without. It's also harder in a contrast study to really evaluate the interlobular septa, which especially if you're looking for either infiltrative processes or fluid overload, having a good having a good view of those and whether they're prominent is helpful. And with the contrast, it's kind of hard to tell sometimes because they are more prominent because they're going to light up with your contrast.
Thanks for giving us those pearls. So what do you think about this CT scan?
Yeah, so I don't think, like, it doesn't look like classic pulmonary edema. So there's a lot of patchy infiltrates. They are kind of mid-lung zone predominant, although in the apical views, there's definitely some involvement in the right greater than the left. It doesn't really have a central versus peripheral pattern. It doesn't spare the peripheries. It's not peripheral predominant. It's a little bit all over the place. There are some ground glass areas. There are some areas that are a little bit denser. And then on the, let's see, just looking through. In the lower lung zones, you can see those air bronchograms that were hinted at on the chest x-ray. And then definitely on the coronal views, you can see a lot of air bronchograms on both sides. The vasculature, the PA looks really generous on this scan, like a big pulmonary artery. And I can't tell, honestly, on this view, it's really hard to appreciate whether there is adenopathy. I would want to scroll through the soft tissue windows. And then there's a pleural effusion on the right side. I would say that this looked pretty consistent with a multifocal pneumonia. It doesn't sit in the bases the way that you would expect somebody that was, say, having chronic aspiration. Yeah, and it's like I said, I would love to see what the lymph nodes looked like, but I can't really see much. I can't see very much in the way of adenopathy on these views.
So knowing what you know now and seeing this, what else do you think that we need in the workup to kind of figure out if this is actually multifocal pneumonia and who's the culprit?
Yeah. This is somebody that I think, we're just meeting her in the ER for the first time. I would really want to know what her clinical course looked like. So after the diuretics and then after kind of the dust settles, she started to get antibiotics. Is she able to come off of the BiPAP? Do things settle down? Again, she's somebody that I would give nebulizers to. And then just kind of based on her clinical trajectory, then I would be thinking about, do I need, what additional workup do I need to do versus is the treatment strategy that I've adopted working? Oh, and I would want a formal echo after looking at this CT scan. Yeah.
Perfect. Do you have any of those data, Nivedita?
Yes, I do have the formal echo data. So I'll tell you what the interpretation read. And then they said that the left ventricle is normal in size, left ventricle is hyperdynamic, right ventricle is moderately dilated, right atrium is moderately dilated, and the ejection fraction of the left ventricle that they estimated was around 60 to 70%. They also calculated the PASP that was around 30.
Interesting. So, this is somebody that, so I want to go down the road of investigating. This is pretty suggestive of pulmonary hypertension. I would want to go down the road certainly of investigating that further. Before we would be able to do that, really, she would need to be closer to euvolemic, which her labs at least and kind of her clinical picture suggests that she is not. Adding to the differential, again, this is something that I would expect to see kind of not escalating in the last 1 week. Go back and look at whether there is prior imaging, always helpful for comparison. So did we mention that she had gone to an urgent care at one point and gotten a Z-Pack? Did they do a
Yes,
chest X-ray at that point? No.
they did. Yeah, she just had like at that point of time it wasn't as severe, so they gave her a Z-Pack and they sent her home,
Sent her on her
and they
way.
tested her for COVID and said you're good.
And then it's sometimes people, they come into the ICU, or sorry, not into the ICU, into the ER for other reasons, and then they get a chest X-ray done. So looking what prior imaging looked like might be a little bit helpful. There are kind of some weirder, there are some weirder causes of pulmonary hypertension that can cause parenchymal changes. PVOD is one of them, tends to have more like nodular appearance than that. I would also be interested in her immune status. So an HIV and a T cell panel and some immunoglobulins would be helpful.
So I don't have the immunoglobulins, but I do have an HIV test, which was negative.
Okay, great. Because HIV can also give you predisposition to more unusual infectious processes, and it can predispose to pulmonary hypertension. And then we kind of talked about the eosinophils, but I would also want to know what her IgE looked like. That kind of the appearance of the how the bronchi look kind of encased almost, they're thicker. Two processes that kind of have classic appearance like that. One of them is Kaposi sarcoma, which again goes back to the HIV. It has that, it's called like the flame appearance on a CT scan. And the other is allergic bronchopulmonary aspergillosis. That's the finger and glove appearance, and would kind of fit with that. The ABPA tends to be more prominent in people that have known diagnosis of asthma, but again, that's my pulmonologist brain wanting to know what IgE is as well.
So week 1 happens, and this week do all of this treatment. The patient doesn't get worse, but she doesn't get better, and this is when we would start thinking for improvement. So we consulted pulmonology, and then they asked us to get all of this as well. So we did get an IgE. Unfortunately, that was also normal. I mean, unfortunately for us, because we didn't know what was happening. And then we then got an ANA ANCA panel as well. And I can tell you, so her ANA, her ANA was noted to be positive, and it had a 1:160 nucleolar pattern with, and her ANCA, C-ANCA, CCP, speckled pattern, ANCA PR3 antibodies and myeloperoxidase antibodies were all negative. We did get mycoplasma and further aspergillus testing as well, and all of that was also negative. And this was, at this point, this was nearing the end of week 2, and she's still on the high flow.
So at this point, you kind of have to have a conversation, unfortunately, about how you safely bronch this patient. Because that's really the next step, is to just understand what's happening in the alveoli. I mean, I would be looking for whether she has eosinophils that might suggest either a drug reaction. And I know we haven't really done a medication review, but you know, did she get started on daptomycin for one of her lower extremity wounds, which can be associated with an eosinophilic pneumonia? A handful of other, I mean, people that have chronic urinary tract infections that are on nitrofurantoin. We'd also be looking to see if we can get a better sample. I wouldn't expect her to grow bacteria at that point because she's been on antibiotics, but you mentioned aspergillus. You can look and see if you have fungal elements. She doesn't really have any reason to have any of the, like a PJP or something that would be more common in somebody with T cell immunity problems. But then also I want to inspect the airways and then see if there's anything abnormal on the airway wall that might give that kind of strange, kind of tubular, very thick bronchial pattern. The hard part here is that she's on high flow nasal cannula. So some patients, you really need to be looking for a window, like they're hypoxemic enough that they need a bronch, but not so hypoxemic that you're going to destabilize them with a bronch. this is really something that I would judge based on how they eyeball. She's somebody that I would probably bronch in the intensive care unit, and be ready to intubate her if necessary, which is a conversation I'd have to have beforehand. The other thing you'd be looking for is diffuse alveolar hemorrhage, which it has a very similar appearance really to pulmonary edema, more than what we were seeing with the air bronchograms. But you've gone down the road of your ANCAs. It's uncommon to have granulomatosis with polyangiitis, or microscopic polyangiitis with a negative P ANCA, eosinophilic granulomatosis with polyangiitis, which was Church-Strauss before, very common actually to have a negative, ANCA. So that's where the eosinophils on the BAL might be helpful.
So that's what we were thinking at this point, because now we're down to this second week, and now her diagnosis has now changed into essentially a non-resolving pneumonia. So we went back and took further history. Then we found out that she was actually having exposure to the nebulizer treatment that she was doing, was she was adding Vicks, like the vapor up solutions, to it to nebulize herself. And then this opened up the differentials for lipoid pneumonia, secondary to Vicks, and then pulmonary alveolar proteinosis, diffuse alveolar hemorrhage that you spoke about, and then of course interstitial lung disease. We did at this point we started treating her with high dose methylprednisone, because we were essentially shooting in the dark without the bronchoscopy, seeing as how she was still on like 7, she would shift between like 100, some days were good days, she would shift between 70. We would hold off diuresis, give diuresis. So it was a very fine line which we were traversing.
And high dose methylprednisolone, are we talking like a 60 Q6 dose? Or are we talking like half a gram?
We started 125, and then went to like almost 125 for 4 or 5 days, went to, when we saw that there was some improvement, went to 60, and then we had to continue with 40 twice a day IV, because any lower than that she would get worse.
So she did respond to steroids?
Very minimally. She just went from being at 90% FiO2 to 60%.
And was there any conversation about antifungal treatment at that point?
There was, and that's why we sent the markers as well, and then nothing came positive, so we held off on it.
Okay. Was there a Fungitel stent? Those can be kind of hard to get. Okay. All right. The Fungitel is the 1,3-beta D-glucan.
We did send the beta. Yes, we did send that one.
Okay.
Yes, that was also negative.
Okay. The other thing, I mean, you mentioned that she's in Baltimore. I mentioned cocci as very common in California. I think histoplasmosis would be worth knowing about on the East Coast. Can cause those patchy infiltrates, tends to cause also a lot of adenopathy. Most people are really not that symptomatic. You find the result of it much later, but they can get a fibrosing mediastinal process. I would not expect really the presentation to be this acute.
Dr. Achamallah, and now that we know that she was given steroids and it didn't change that much her clinical course, what is on your mind after that? Because I feel like steroids are usually kind of like the cure for a lot of things, and this is not the case.
Yeah, I'm still worried about infectious. I'm a little bit worried about rheumatologic. I would expect anything. I mean, we saw the ANA, but like I'm not that impressed by a 1 to 160, especially we said that there's a dsDNA that was negative.
Yes.
Did the ANA, I mean, did the ANA usually, if it is positive, it will reflex to give a panel of other antibodies, so like SSA, SSB, that might clue you into, you know, and you go down the road of asking about dry mouth, dry eyes, kind of Sjogren's related. The rapidly progressive interstitial lung disease can be associated with myositis or dermatomyositis, but again, you would expect her to have other symptoms. Sometimes the lung disease can predate that, but tends to have more of a kind of diffuse ground glass, exuberant appearance on imaging, which this really was not. It was a little bit more patchy. Ideally too, you would be going down the road of investigating the pulmonary hypertension as well. But I mean, finding a cardiologist that's going to do a right heart cath on her is a little bit problematic. I mean, there are etiologies of pulmonary hypertension that can cause these kinds of changes on the CT scan. The hard part is figuring out what of the hypoxemia is being driven by what. So at this point, have you got repeat imaging at this point? I would probably repeat the CT if after a month or after a week we're not getting better, and then decide if parenchyma or vasculature is really driving the ship.
So we did get further imaging, and I can share that again. Sorry, this is the old one. This is the new CT scan, and I do have the other views.
So ideally, we would be able to compare the two. But in some of the views, it looks like maybe where there was more ground glass, the ground glass has started to settle and there's some denser areas. I think on the bottom right in that view, I don't remember there being quite such dense consolidations there before. You see that there's a much larger kind of wedge-shaped area almost. Yeah, exactly. And then in the base of the right lung, kind of towards the medial aspect, and then in the base of the left lung too. So a lot of that is kind of denser and more confluent than it was previously.
I can show this is her previous one just to compare.
Yeah. So see where there's that kind of dense kind of wedge-shaped area in the right lower lobe. Previously, there was some ground, even no more anterior. Previously, there was some ground glass in those air bronchograms, and then again on the left side, it's denser than it was. So whatever we're doing, it's not working.
That's where. Sorry. Do you want me to share the screen again?
No, that's okay. So did she get a bronchoscopy?
Yes. So we spoke to her eventually, and then we had a whole goals of care conversation. And then we found a good window, and then one of my attendings, he does a lot of nasal approach bronchoscopy, so we did it that way since we found it a little bit, it was too high risk to go intubation, and then because we were worried about the high risk of her staying intubated longer. So we did the intranasal bronchoscopy, and she had we had a biopsy of the right upper and the right lower lobe, and then it showed a. So should I stop here? Or are we waiting?
I think that this is like the final piece of information with the
Yes.
biopsy to confirm. But what are your final thoughts on what we know about this case, and what are you expecting the biopsy, Dr. Achamallah?
So honestly, I'm not really sure. So I'm pretty satisfied that we have given her an adequate course of antibiotics. We do have the complication of the pulmonary hypertension. I actually, my kind of conversation that I would be having with myself is twofold. You would love transbronchial biopsies, but in patients that do have pulmonary hypertension, that can be really dangerous actually, because they're higher risk of bleeding. I imagine that they did not see anything out of the ordinary in the airways themselves. If I did, I might go after biopsies for that. Really, the only kind of parenchymal lung diseases that are especially useful, that the endobronchial or the transbronchial biopsies, sarcoid is on that list. And hypersensitivity pneumonitis is also on that list. Her imaging is not exactly classic for hypersensitivity pneumonitis, but again, you have to think about in your differential things that are going to be steroid responsive and things that are not. Hypersensitivity pneumonitis generally is exquisitely sensitive to steroids, so that's again lower on my list of differentials. A non-resolving pneumonia, especially one with kind of fleeting infiltrates, I would be thinking about an organizing pneumonia, but again, organizing pneumonia, very steroid responsive usually. So that also goes lower on my differential diagnosis. So I think probably we're either dealing with a fungal infection. So we've mentioned aspergillus before. You know, she doesn't really necessarily have risk factors. I'm curious about how much she's cleaning that nebulizer that she that she is putting Vicks VapoRub in. So, I mean, something that she's nebulizing that we're not getting at with our antibiotics would be high on the list.
So before I give the pièce de resistance, I'm gonna say that we went back a little bit and then we found out that she had actually had a significant amount of weight loss of about 20 to 25 pounds in the last 6 months. And her biopsy actually showed, unfortunately, poorly differentiated carcinoma with necrosis, which was suggestive of a gynecological primary, which ties her into her past medical history with her sister having breast cancer as well.
Yeah. Would not have called that, not on the top of my list. Yeah. It's interesting, you know, for a gynecological primary to show up with that appearance is really interesting, because primary lung cancers can definitely show up and fool you and look like pneumonias. I've had a few of those even in the last 6 months. And they tend to go along with somebody that has a lot of risk factors for cancer. You know, her CT scan really does not follow that, that appearance of something that's metastasized. They tend to look much cleaner, but I mean, she could absolutely have a superimposed inflammatory process that is kind of making those borders cloudy. That's why some of that ground glass maybe got better, but the denser consolidations got worse. Wow, poor lady.
Yeah, unfortunately, after all of this, she's been, at this point, our patient has been here with us for the last a month now. So we did send markers and her CA125 was around 115. And her CA15, 3, CA27, they're all elevated. We did also send CEA and CA19 as well, just because there was a concern when we got band scan images just to look for any other foci of malignancy, just to rule out any GI causes. But at this point, it looks like after talking to her, she was unfortunately transitioned to comfort care.
Thank you so much for sharing this case. It was so rich in so many things, and I think that it took us to very different routes and very different differential diagnosis. Unfortunately for the patient, this was a very tough diagnosis. But then again, thank you for sharing this with us. If you had to choose 3 very important teaching points from this session, what would you leave us with, Dr. Achamallah?
One of them is, you know, the first thing that you do is stabilize the patient, you know, so really understanding, you know, first of all, that we met this patient in the ER before you can go down the road of really delving into a rich differential, making sure that they're safe and making sure that they have the interventions that they need to, you know, give you time to do those interventions. So getting this lady on BiPAP, trying diuresis, nebulizers. Another is to really keep your differential very broad and not stop looking. So, you know, you have probably all seen dozens of community-acquired pneumonias that look just like this. You know, we have the benefit of being in a situation where you have to assume that something more complicated is going on. Otherwise, we wouldn't be talking about this case. But this could be your patient that walks in with a simple community-acquired pneumonia tomorrow. and really to keep questioning yourself as you go and decide, is what I'm doing continuing to make sense? Okay, today it makes sense, tomorrow we're not better, something has changed. So what has changed, and is what I'm doing still making sense? You know, the next day there's new information. Okay, I need to start from scratch and just make sure that I am keeping all of that new data in mind. So rather than just kind of having that, I'm treating this person for a pneumonia in 3 days. I'm like, is this acting the way I expect a pneumonia to act? Maybe I need to explore and see what else might be going on.
Thank you so much to everyone for their time, Nivedita for bringing this case, and Dr. Achamallah for leaving us with these pearls. Thank you to Dan, who did a wonderful job scribing. As you can all see, the whiteboard full of information. And thank you so much to Umaima as well for doing teaching points, so we don't forget anything. Thanks everyone for attending. Have all a wonderful afternoon.
Thank you all very much.
Thank you.